Welcome. Welcome to those of you just joining us to today's Aging Well with Vision Loss webinar. As people file in, we will get started here in just about a minute. We have a few housekeeping things to go over, and then we will turn it over to our presenter. My name is Katie Frederick, and I am a digital content manager with Vision Aware, part of our APH Connect Center. And again, just want to welcome everyone to today's presentation with Dr. Sefy Paulose on aging well with vision loss. And I here am going to take a moment and pause the recording so that we can give out the opening ACV REP code for those collecting credit. All right, welcome to today's Aging Well with Vision Loss webinar. My name is Katie Frederick, and I am a digital content manager with Vision Aware, part of the American Printing House for the Blind Connect Center. Today's webinar is on aging well with vision loss, and we are thrilled to have Dr. Sefy Paulose joining us today. She will present on some normal changes in the eye, as well as eye conditions related to aging. And she will discuss what happens in the eye as a result of these conditions and treatments, protocols, and current research during today's hour-long webinar. So a little bit about Dr. Paulose. She is an ophthalmology resident training at one of the nation's top ophthalmology residency programs, New York Eye and Ear Infirmary of Mount Sinai. Prior to pursuing ophthalmology, she completed her undergraduate and medical school education through a combined 7-year program at Drexel University College of Medicine. Dr. Paulose has contributed to the ophthalmologic literature with published articles in academic journals, presentations at national conferences, and is a co-author of a book chapter on glaucoma. Additionally, Dr. Paulose has reviewed the eye condition sections on Vision Aware and updated them with the most current information. So it is our pleasure to welcome Dr. Paulose to today's presentation, to our webinar. Thank you very much for joining us. And for those of you who are here, do feel free to put your questions in the chat. Make sure you change the to everyone so that we all see your questions, and we will go from there. So thank you. If you need ACV REP credit, that code is in the chat for your information. So Dr. Paulose, I will hand it off to you. Thank you very much for joining us this morning.
Thank you so much for having me, and thank you so much for that introduction. Good morning, everyone. Thank you all for joining me this morning and taking some time out of your morning to learn about some age-related eye conditions. My name is Sefy Paulose, and just like Ms. Katie had mentioned, I'm an ophthalmology resident at New York Eye and Ear Infirmary of Mount Sinai. The purpose of this talk is for us to learn and discuss some common eye conditions that affect us as we age. And I think this is fitting because May is the month that we observe Older Americans Month, as well as Healthy Vision Month, which is observed to help bring awareness to our overall health as we age. And I think it's important to know what conditions are common in order to help prevent worsening vision and ultimately blindness. Okay, so there are many different eye conditions and diseases that I would love to discuss today, but given our time restraints, and since I definitely want to hear from all of you and answer any questions that you may have, I will be discussing the 4 most common and preventable eye conditions, each of which is a major cause of blindness in America. So the 4 that we will be discussing today is cataracts, glaucoma, diabetic retinopathy, and age-related macular degeneration. But before we delve into these eye conditions, I do want to just review generally how vision works and how our eye sees, which will help us understand what we're talking about. So this photo shows a balloon, and as light comes into the eye, it gets bent through different structures in the eye. And that light then just gets directed to the center part of the back of our eye. The back of our eye then sends signals to the brain, and that's how our brain gets the image that we see. So it's a pretty remarkable process, but all gets done in the split of a second. And that is what vision is. So our first topic will be about cataracts. So what are cataracts? Cataracts are the leading cause of vision loss in the world. So the World Health Organization, which is the WHO, has estimated that cataracts cause about 51% of blindness in the world, and has estimated that more than 20 million people are blind due to cataracts. However, 90% of these cases of blindness from cataracts is found in developing countries, as there are limited resources for screening and treatment. But it's still very important in America and for us to know as well. So what is a cataract? A cataract is a normal part of aging. It's when the natural lens inside of the eye becomes cloudy and hardens over time. So everyone has a natural lens inside of their eye. And in this photo, the lens is where it points to. And this arrow that points to the healthy lens inside of our eye is what acts similarly to a camera lens. And this is what helps focus light onto the back of the eye so we can see. When we're born, this lens is clear and very flexible. So it's easily able to bend light right into our eye without any issues. But as we get older, the lens inside of our eye hardens and it changes its color from being its normal transparent lens into a yellowish brown tinted lens. I usually describe this to patients as you can think of it, our lens as like an onion. So as onions have many different layers, similarly, as we get older, the lens also grows these additional layers, and those layers can make it more and more cloudy. There are various types and forms of cataracts, but the most common cause of cataracts is just with aging. And it's thought to be because of oxidative damage that causes this cloudiness. So oxidative damage is just a very fancy word for the aging process that we will all go through. And it's very similar to the same oxidative damage that causes wrinkles on our skin. So another thing I'll usually tell patients is that a cataract is a normal part of aging. Just like we all get wrinkles, the same way the lens goes through this change. But what other things can cause cataracts? So trauma to the eye can cause a cataract or accelerate the process of cataracts. So getting a blow to the eye, punch to the eye, hit in the eye can all cause that. Other types of medications can also accelerate the process of cataract development. So specifically, some types of eye drops can accelerate or quicken the cataract development. Other like systemic conditions like diabetes, diabetic retinopathy, uveitis, hypertension can all lead to cataracts as well. And one of the most modifiable risk factors, meaning things that we actually have control over, is smoking. Smoking and poor nutrition can increase the progression of cataracts. And the CDC actually says that those who smoke about 20 or more cigarettes a day have twice the risk of developing cataracts as compared to non-smokers. So how can we get screened for cataracts? So the talk today is just going to be to go to your ophthalmologist and have that annual eye exam. It's the best place to start. But also keeping in mind what the symptoms of cataracts are. So like we discussed, there are many different kinds of cataracts. So one person's symptoms may be different from another. But in general, you may find that your vision starts to get blurry or a little hazy. Some people say that, it's hard for them to see those fine details that they used to be able to see so well. Others may describe it as like looking through a dirty window shield. It's something is just not crisp and clear like it used to be. Others will kind of say the same thing. It looks like there's like dirt or like a streak over my vision. And all those things could just be signs of a cataract. So this photo on the left is a photo of a young boy in front of a field of flowers, and it has white and yellow and red flowers behind him. And in the photo on the left, it actually looks like there's like a white, cloudy or smudged blur over his face, which makes it difficult to see his features, specifically his eyes and his nose. Even his mouth is a little bit covered. Others, though, may find that their vision is intact, but their contrast to colors has changed. So the photo on the right now shows that same photo of the young boy, but this time with a brown or dull tint over it. You can't really appreciate the color of his eyes or the flowers behind him. And these are all just different ways that cataracts can present itself. Other people may have problems driving at night. So glare tends to bother people. So specifically when they're driving at night, the oncoming headlights glare prevents them from seeing as well as they used to. So if you have a cataract, what do we need to do about it? And for most people, like I said, nothing needs to be done. Many people have cataracts that don't have any visual symptoms because, like we said, cataracts is just a normal part of aging. It's like having wrinkles on our skin. Just because you have a cataract does not mean it should be removed. So if you're told you have a cataract at your eye exam and it doesn't interfere with your activities of daily life, or if you're able to lead an active and productive life, your doctor may just tell you that we can just monitor this cataract. But if you are experiencing those difficulties like we discussed, so reading, glare, or just difficulties engaging in your normal activities of life, it may be time to start to think about treatment. So as of now, there are unfortunately no medications or eye drops or anything that can reverse cataract formation. So the permanent fix for cataracts is to remove the cataract surgically. And in this procedure, what happens is that you will be taken to the operating room, and the surgeon or your ophthalmologist will make small holes around your eyes to use tools that they can then put inside of your eye and break up and remove the cataract, similar to the photo on your right. So on the right, we see a diagram of the eye. It's a cross-sectional diagram, meaning an eye cut in half. So we can see the lens, which is the circular piece in the middle. And you can see that there is a probe that's now inside of the eye and breaking up that natural lens. And that is cataract surgery. After removing the natural lens in the eye, the surgeon will then place a replacement or an artificial lens inside of the eye. This lens is fitted just for you. It's particular to your eye and your eye's prescription. And allowing that lens to be in your eye allows us to see much better than when our cataracts were there. So that is what our first topic is about, cataracts. I'm happy to answer any questions now, or we can answer questions at the end.
So if you have questions, do feel free to put them in chat if you like, and we can take them as they come in. I'm not seeing any at the moment.
Okay, so then we will just move on to our next topic. Our next topic is glaucoma. And glaucoma is the most common cause of preventable but irreversible blindness in the world. Irreversible meaning that once vision has been lost, it can never come back. It's responsible for about 13% of blindness in the world, and nearly 2% of Americans over the age of 40 have open angle glaucoma, which is a particular kind of glaucoma. So let's go into talking about that. So what is glaucoma? To understand glaucoma and its treatment, it's important to understand a little bit more about our eye. So you can think of our eye as a ball or a balloon. There's a certain amount of pressure that is needed to be kept inside the eye to allow that ball from being deflated. So similarly with a soccer ball or another type of ball or balloon, the eye needs a certain amount of pressure. And in a healthy eye, fluid called aqueous humor, it's just a particular type of fluid, is continuously made in the eye and drained appropriately to maintain a healthy eye pressure. So you see on the photo on the right, so this one right here, it shows a close-up of what the normal drainage system of the eye is. So we can see these arrows are just showing where this aqueous humor is made, or this fluid is made and drained appropriately out of the eye. So this is not related to blood pressure. I just wanted to say that because sometimes there is a little bit of a confusion, and eye pressure has its own fluid unrelated to blood pressure. Sometimes though, there's too much fluid being produced, or the drainage system itself is blocked, which can cause the pressure in the eye to build up. So you can think of this like a kitchen sink. So if the drainage system of that kitchen sink is blocked, or if you keep that faucet on, the kitchen sink will overflow with water. But in the eye, there's really nowhere for that overflow of water to go. So then the pressure in the eye just continues to go up and raises. And this is important to understand because over time, this increased eye pressure can cause damage to the optic nerve. So the picture on the left shows the eye, and it just is a diagram that states that there's pressure built up and shows that there are changes happening in this optic nerve, which is right here. And the optic nerve is a cable that connects the eye to the brain. So another example that I usually tell our patients is you can think of the eye like a camera. It takes photos and information from the outside world. And you can think of the brain like a computer. It processes those photos. And the optic nerve is a cable that connects our eye to the brain. So that camera to the computer. If the camera is working fine, that's great. But if the optic nerve or that cable is damaged, the brain does not know what it's seeing. It's not receiving those signals. So that is why glaucoma is an irreversible disease. Once there is damage or a loss of a part of that optic nerve, there's no way to get that part of the nerve working again, which is why it's very important to see what we can do to prevent this from happening. So what causes glaucoma? And this is a really hard topic to talk to patients about. There are various types of glaucoma, but in general, we don't really know why some people get glaucoma and others do not. The one thing we know for sure is that glaucoma is related to eye pressure, like we just discussed. Other reasons why some people may be more susceptible to getting glaucoma is age. So those over the age of 60 have a higher chance of getting glaucoma. There are also some ethnic backgrounds that are more predisposed to certain types of glaucoma, specifically those of Asian descent, Hispanic descent, or African descent have an increased risk of developing glaucoma, maybe even at an earlier age, or maybe even at a more advanced stage than those of Caucasian individuals, for example. And then the other thing that we know is that family history of glaucoma. So if someone in your family has glaucoma, that may put you at a higher risk for developing glaucoma based off of just genetics and our DNA. So how do we get screened for glaucoma? Glaucoma is often called the sneaky thief of sight because the symptoms or early warning signs of glaucoma are very subtle, and it's usually not noticeable until it's too late or very advanced. That's why the best way of reducing your risk of experiencing permanent vision loss from glaucoma is to just go for your regular comprehensive eye exams. Get that dilated eye exam by your ophthalmologist. So with periods of elevated eye pressure in the eye, damage happens to the optic nerve, but specifically to the outskirts of the optic nerve, which is what results in a peripheral or side vision loss. So the effect can be kind of like what we see in this picture on the right. It's like looking through a tube or into a narrow tunnel, which makes it difficult for patients to walk around as they might bump into things or walk into things. So as the disease progresses and the optic nerve continues to get damaged, the field of vision continues to constrict and constrict until it's complete vision loss. So this photo that we see on the left gives you an idea of what this might look like. On the left, it's a picture of what we would see if we were driving a car. So it's a picture of a car, and you can see on the road, there are a few cars on the left, a few cars in front, and then a truck on the right. And then the photo on the right shows us what this tunnel vision or a patient with glaucoma might see. So all we can see now is this one car directly ahead, and all the other cars and trucks are completely obscured. So what is the treatment for glaucoma? Like we said, glaucoma is an irreversible disease. So unfortunately, once there is loss to that nerve or once there is damage to that nerve, we can never get that part of our vision back. So the name of the game here is to prevent any worsening or progression of glaucoma. So the first line of treatment is to help decrease the eye pressure with eye drops. So these eye drops in particular can help decrease the production of fluid in the eye. So kind of thinking like turning off or kind of keeping that faucet, that kitchen faucet, a little bit lower in terms of the amount of fluid that's coming into the eye. If eye drops don't adequately control the eye pressure, or if the glaucoma is still progressing, your ophthalmologist may consider doing other treatments. So another treatment might be to do a laser. So this type of laser will vary based off of the type of glaucoma that you have, but ultimately the point of the laser is to help decrease the eye pressure. So in this case, what can happen is that it increases the drainage system of the fluid of the eye. So going back to our kitchen sink example, it's like putting another hole in that kitchen sink. This allows the water to go out a different way, so that way the eye pressure or the sink pressure won't be too high. And if laser, just as another example though, this laser is different from other types of lasers that you might hear. So LASIK and PRK is a different type of laser. And I just wanted to keep that in mind as well, so there's no confusion. And the last line of treatment, if lasers don't work, would be to do surgery. And this type of surgery will depend on the type of glaucoma you have. But this is also to increase the drainage system of the eye even more. So either by putting a tube or a stent or a shunt or something else to kind of help with the drainage system of the eye. And any other questions about glaucoma or cataracts from what we had discussed previously?
Yes, we do have a few questions. So someone is asking about about IRL lenses and what are they and how are they different?
Yes, so there are many different types of lenses in the eye that we can do for cataract surgery. It really depends on the potential of vision that you have. So there are toric lenses, there are phaco, there's just many different ones. So I would speak to your ophthalmologist and see if that particular lens is great for you. It also depends on if you want near vision, if you want to be able to read without wearing reading glasses, or if you want to be able to see distance without glasses. Those are all different types of lenses that we can get for that artificial lens that we talked about when we do cataract surgery.
All right. Next question. What is the difference between open angle glaucoma and closed angle glaucoma?
That is a great question. So for that question, I'm just going to go back to this diagram right here. So like we discussed, glaucoma is when there is damage to the optic nerve in the back of the eye. Open angle glaucoma means that the angle, which we describe as the drainage system, is open, meaning that if we go back to this photo, I don't know if you can see my mouse here, but this is what we're calling the angle. This is the drainage system of the eye. If the angle or the drainage system is open, we call that open angle glaucoma. So for some reason, the eye pressure is high, even though the drainage system is working very well. Versus closed angle glaucoma is if we go to this photo, is when this angle or the drainage system is closed, meaning that the drainage system is blocked in some way. So the treatment for these cases is a little bit different. The people that are more susceptible to open angle versus closed angle is also different. And the surgical treatment for these two conditions is also different as well.
Great. The next question, so someone has seen people with plugs in their eyes and wondering if this can cause glaucoma.
That is a great question. So the punctal plugs that this person is discussing is actually for a different type of drainage system of our eye. So we have a drainage system inside of our eye that keeps the pressure what it is, like I said, the ball example. So keeping the eye pressure at a certain level versus I am sure we have all cried at some point in our lives. And we have a different drainage system for our tears. So our tears drainage system is actually on the inside of our eyelids on both the upper and the lower part of our eye. I don't have a photo of that, unfortunately. So punctal plugs are placed in that drainage system to kind of keep your tears for a longer period of time. So this is a particular treatment for dry eye syndrome, which is actually not related to the drainage system that we're talking about, which happens inside of the eye. But that was a great question.
All right. And then we have a couple more here asking about how you measure the pressure of the eyes and then how much is needed.
That is a great question as well. So eye pressure, unfortunately, can only be done when you go to your ophthalmologist. We don't have a tool that you can use at home, similar to a blood pressure cuff. Unfortunately, we don't have that. So what the eye doctor will then do is that they will check your pressure by using either a tool that is portable in their hand or at the slit lamp. The slit lamp is a large microscope that we use. And the way that it checks pressure is by pushing on your eye with that tool. And that tool will then calculate the amount of pressure that is in the eye by just that simple touch. Prior to checking your eye pressure, you will be anesthetized, which means that they will put an eye drop in your eye so you don't feel that tool touching your eye, because as you can imagine, that would be pretty uncomfortable. And that is how they check your eye pressure. Regarding the second part of that question, that is a great point. So everyone's eye pressure depends on that particular person. We like to say that a normal eye pressure should be under 21 mmHg, which is just the units that they use. But just because your pressure is below 21 does not mean that you don't have glaucoma. Because again, glaucoma just means that there's damage to the nerve itself, regardless of what your pressure might be. So someone who has a pressure of 15 may still have glaucoma because for their eye, that pressure is too high. Or someone else might have a pressure of 22, but they don't have glaucoma. And that's because even though their eye pressure is 22, it has not caused damage to the optic nerve in the back of the eye.
Those are all the questions at this time. And just so people know, we are putting some resources in our chat from our Vision Aware website, which contains a lot of great information on many of these eye conditions. So thank you to my colleague, Chris Rogers, for putting some of those links in chat, and feel free to check those out as well for additional resources. So back to you, Dr. Paulose.
Okay, so our third subject today is diabetic retinopathy. And diabetic retinopathy is a major cause of blindness in America. So as you know, we do have the diabetic endemic going on in America. The CDC says that 7.7 million people of working age in America have diabetic retinopathy. And it's noted to be that about a third of people with diabetes over the age of 40 will have diabetic retinopathy. 5% of those people with diabetes will have vision-threatening diabetic retinopathy. And this is actually the leading cause of preventable blindness in America, preventable being that we could stop this from actually happening. So what is diabetic retinopathy? Retinopathy is just a general term that describes damage to the retina, which is a film that lines the back of the eye. So like we discussed previously, light is bent through different structures of the eye, which we kind of discussed before, to hit the retina in the back of the eye, which is pictured here on the photo on our right. And this retina has nerve cells that convert that light into electrical impulses, which is then carried by the optic nerve to the brain. So that way our brain can interpret what we are actually seeing. So the photo on the right here is a diagram of a cross section of the eye, specifically showing what a normal and healthy retina should look like. Just like diabetes affects blood vessels in the heart, the kidneys, the legs, the brain, all blood vessels really, the same way diabetes can cause damage to the small blood vessels in the retina, in the back of the eye. So when diabetes becomes uncontrolled or out of control, the high amount of sugar that is in those small blood vessels can cause damage to the blood vessels. And that can cause those blood vessels to bleed or leak. And it prevents those areas of the retina from getting the nutrition that it needs. So this can cause those areas of the retina to become damaged or even dead. Dead retina then can lead to new or bad blood vessels from growing. And those blood vessels are even more likely to bleed. They can leak even more, and they cause worsening damage to the retina. It's kind of like a domino effect at that point. And so the photo on the right is a similar photo or diagram as our previous slide, but this one actually shows what the retina looks like when we have damaged blood vessels in the back of the eye from diabetes. So like we discussed, what causes diabetic retinopathy? It's uncontrolled blood sugars that can increase your chance of having diabetic retinopathy. So the best way to know if your diabetes is under control is by following a blood level that your primary care doctor may draw, which is called a hemoglobin A1C. So this gives you a picture of what your sugars look like over the past 3 months. Although it is helpful to know what your sugars look like on a day-to-day basis, this 3-month interval helps us see how well controlled your diabetes is. So the number really should be less than 7% is what the A1C target really should be. But if your A1C is greater than 7, or based off of what your primary care doctor says, if it's not controlled well enough, it's very important to speak with your primary care medical doctor to be sure that you're on the right medications in order to help improve your sugars. Like we discussed, it is a domino effect. Once there's a little bit of damage to the retina, it causes more of these bad blood vessels, which can cause more bleeding, which then cause more blood vessels. So it's extremely important to prevent this from happening in the first place by controlling our sugars. So how do I get screened for diabetic retinopathy? As you may have noticed, there's not many signs of diabetic retinopathy. So the best way to protect your eyes from diabetic retinopathy is to, again, have those regularly scheduled annual eye exams, or however frequently your ophthalmologist tells you. So during this examination, your ophthalmologist will dilate your eyes by using a few drops. This helps open up the pupil, which is that colored part of our eye, and it helps the ophthalmologist then shine light through the pupil to assess your retina and see if there are any signs of diabetic retinopathy. So the photo on the left shows what someone with normal vision will see when they're looking at this photo of 2 boys smiling and holding a soccer ball. Versus the picture on the right shows what it might look like with someone with diabetic retinopathy. So we can see that there are patches of black spots that is actually from the areas of the retina that have bleeding and leakage, or areas of the retina that are dead and not able to pass those signals over to the brain. And what are the treatments for diabetic retinopathy? So again, just hammering it home, the best way to treat your diabetic retinopathy is to control your diabetes and to follow up with your scheduled eye exams. So if you have a mild case of diabetic retinopathy, you might not need any further treatment. Your ophthalmologist might tell you to just really diet, exercise, and make sure you're on the proper medications to help control your diabetes. But if you do have more advanced diabetic retinopathy, your ophthalmologist may treat you with various other treatment modalities. For example, one would be an injection of a medication into the eye. So that is an eye injection, and that medication stops new bad blood vessels from growing. So it kind of prevents that domino effect. Again, it doesn't completely take away the damage that was already done, but it can prevent further worsening of the diabetic retinopathy by stopping those bad blood vessels. Based off of your eye exam, though, your ophthalmologist may say that these eye injections are not enough and you may need a laser treatment. So there are a few various laser modalities that we can do. One of which is called pan-retinal photocoagulation. It's a big fancy word for just lasering the outskirts of your retina. So the purpose of this laser is to slow down the leakage of fluid and blood in the retina by specifically just lasering and burning the dead retina. So that, again, that dead retina is what's causing bad blood vessels from happening. So by burning the dead retina, it prevents bad blood vessels from growing more and more. And again, just to say it one more time, this laser is different than LASIK and PRK, which is another type of laser surgery. But if they're still concerned for worsening diabetic retinopathy, your ophthalmologist may actually suggest doing a surgical treatment, which we see here on the picture on your right. This is called a vitrectomy. So vitrectomy is the removal of the vitreous, which is the jelly or the transparent gel that fills the inside of the back of our eye. So that in this photo is the center area right here. So by removing the vitreous, it actually helps remove any blood in the middle section of your eye and prevents further blood vessels from growing in that area and worsening vision. Any questions about diabetic retinopathy?
We do have a couple of questions that came in.
Mhm.
So for diabetic retinopathy, does diabetic retinopathy occur for type 1 and type 2 diabetes? And once diagnosed, can controlling blood sugar levels help prevent diabetic retinopathy?
That is a great question. So yes, diabetic retinopathy can happen with type 1 and type 2 diabetes. Type 1 and type 2 diabetes is based off of the amount of insulin that an organ in your body can create. And once diagnosed, it is hard to manage diabetic retinopathy. Depending on the stage of diabetic retinopathy that you have, you may be able to prevent it or help eliminate it altogether. If you are found to have diabetic retinopathy at a mild stage, you may be able to help control your blood sugars, and those bad blood vessels will not allow them to further grow and further worsen your vision and your eye. Once we get to kind of the more advanced or severe stages where we need lasers and surgery to control the diabetic retinopathy, it is a little bit more difficult to control diabetic retinopathy by just controlling your sugars. We always still recommend controlling your sugars because at the end, we could prevent it from further worsening. But at that point, there's already areas of dead retina, which is releasing all these bad blood vessels, which cause it to further, like we said, that domino effect. So that is why we kind of try to hammer home that if you have diabetes, go for your eye exams. Let's get the diabetes under control so we can prevent diabetic retinopathy altogether.
Great. Next question, is laser a temporary treatment, and might pressure rise again after that's done?
That's a good question as well. So laser is a temporary treatment. What it does is that it again kills off the bad retina that's releasing all these bad signals. And those signals are the ones that cause more blood vessels. And these are, again, bad blood vessels that are very leaky and just want to break and bleed immediately, actually. So the laser, what it does is that it just kills off that part of the retina that's already dead and bad. It's temporary in the fact that just by doing that, that doesn't mean that your diabetic retinopathy is under control, because you may still continue to have worsening areas of diabetic retinopathy. So some people may need multiple laser sessions, or they might need to get laser. Their diabetes is under control. The bleeding in the back of their eye is okay. They might need further injections, but after some time, the area of that was not lasered, or that area that's still releasing bad signals and more blood vessels, may again need to be lasered. So we do a fill-in kind of laser for some people who are not controlled with the first laser that was done.
Okay,
And
a couple more.
Mhm.
Oh, go ahead.
Oh, and the pressure aspect of it is a little complicated. Laser can cause a pressure in the eye to intermittently be elevated or high because of just inflammation that happens inside the eye. But again, it's a risk benefit kind of scenario. So depending on how bad your diabetic retinopathy disease is, your ophthalmologist might still recommend getting the laser, because it just intermittently makes your eye pressure high, and we can always give drops to help that.
Okay, a few more questions here. What is a retinal detachment?
Great question. So that's one of the topics I wanted to add on this presentation, but did not. Retinal detachment is when the retina in the back of the eye breaks off from one point of the eye. So like we talked about, the retina is a film that covers the back of the eye, and it's what helps us see. So it has all those nerve cells that change the signal from a light into an electric pulse, so it can be sent to the optic nerve. If the retina detaches, then you can kind of think of it like that film is off of the eye. So those nerve cells are no longer attached. If those nerve cells are not attached, then that part of the retina cannot work. So it cannot transmit the signals that it needs to send to the optic nerve. So retinal detachment can happen in patients with diabetes, because all that leaking blood vessels can cause the breakage of the retina to come off of the back of the eye.
All right. How is diabetic retinopathy related to retinopathy of prematurity in infants?
That's a great question. So retinopathy of prematurity in infants happens because of also leaky blood vessels that are just not completely or fully developed. Diabetic retinopathy is actually not related, but the mechanism of both conditions are pretty similar in terms of the fact that we have leaky blood vessels that are bad, that can cause areas of the retina to be damaged or ischemic, meaning dead, which can then cause retinal detachments. It can cause more bleeding. It can cause more swelling of the back of the eye. So the treatment of retinopathy of prematurity also includes these eye injections. It can also include surgeries depending on the severity or the stage of the prematurity, similar to diabetic retinopathy. But they are two completely different entities, or two completely different diseases, although we could kind of think of them as being related based off of the mechanism of how it happens.
Great. And we have just a couple more questions here. What advice is there about medical exams or treatment for a person who has no vision due to diabetic retinopathy?
So regardless of what your vision is or visual acuity is, it's still extremely important to go to your eye doctor and still get those exams. Although, unfortunately, if we do completely lose vision, then the next step is to prevent any pain, or even just to keep the eye itself. Diabetic retinopathy, like we talked about, has those really bad blood vessels. And even though we lose vision at the most severe or advanced stages of diabetic retinopathy, we still want to control the diabetes and control the diabetic retinopathy, because what can happen is that those bad blood vessels can then grow into the drainage system of the eye. So kind of going back to glaucoma, it can block that drainage system and cause the eye pressure to be really high. And this particular type of glaucoma that's related to diabetic retinopathy, which is what we call neovascular glaucoma, which just means new blood vessels kind of that block the drainage system. This can cause an extremely painful eye because the pressure is just very out of control. And no matter what drops we use or injections or anything, the pressure can get so high that the pain is almost unbearable, to the point where the eye may need to even be removed. So regardless of the vision potential that you have, it's still extremely important to get the diabetes under control. It's still extremely important to follow up with your primary ophthalmologist to make sure that we don't get to more and more advanced stages of this diabetic retinopathy. But that was a great question as well.
All right, and someone is thought that the vitreous humor was essential for the eye to maintain its shape and form.
That is a great question. So aqueous humor is the fluid that we were talking about that is created in the front part of the eye. So that helps with we need a certain eye pressure, or that aqueous humor pressure, in order to keep that ball or the eye from being deflated. 100% very true. The vitreous is the jelly that's actually in the back of the eye. So this is a transparent jelly that is almost like a scaffold of the back of the eye, or I don't think you can see my mouse here, but it's this area in the back here. So that when it's removed, it's actually okay to be removed, because the form of the eye is already shaped and the aqueous humor is still there. So the surgery that's done for the diabetic retinopathy is just what we call a pars plana vitrectomy, which removes the part of the vitreous that we don't really need as the scaffold of the eye.
All right, and the last question that we have for the moment is, why does one have to have cataract surgery within a few months after the vitrectomy? And I apologize for my pronunciation.
No, that's great. That is a great question. So that goes into more of the oxidative damage that we kind of talked about briefly when we talked about cataracts. So although the vitreous is a scaffold of the eye, it's thought that for some reason, the vitreous helps slow down oxidative damage, or this aging process of the lens inside of the eye. So which is what the cataract is. When we remove the vitreous, the lens oxidative process speeds or accelerates, actually, to the point where the cataract that would have normally occurred, let's say in maybe 10 years or 15 years, may occur in just a few months or even just a year. So some people, after they get the vitrectomy, may need to go back in and get that cataract surgery a little bit sooner than what a normal cataract formation would have been. So sometimes your ophthalmologist will recommend just doing both surgeries at the same time. So they would do a cataract surgery with a vitrectomy, depending on the reason for why that vitrectomy is happening, in order to prevent you going into the eye twice. But again, that's usually not done unless you already have a cataract, because we don't like to just do extra surgery without any reason or cause for it. So if you already have a cataract and you have diabetic retinopathy that's out of control or uncontrolled, and you need a vitrectomy, then you may end up doing both. Otherwise, you would just do the vitrectomy, and then when you get a cataract later on, the cataract can just be removed, because again, it all depends on your eye. And just because one person gets a cataract 2 months after their vitrectomy, another person, oxidative process, just the aging process of their eye, might not be as fast, and they can maybe hold off for another year or a few years even.
All right, there are no other questions at this time.
Okay, and then our last subject for today is age-related macular degeneration, which is a very long word. So sometimes I will be calling it AMD. So this is the leading cause of blindness in America for people over 65 years of age. And it's estimated that among North Americans, there's about 11 million people who have dry AMD, which is one form of age-related macular degeneration, and another 1.5 million people have wet AMD, which is a little bit more of an advanced or quick progressing type of macular degeneration. So what is age-related macular degeneration? Like we discussed, the retina is the structure in the back of the eye that is almost like a film. So it's as if it's like a camera that records all of the pictures and it's getting all those signals. Will then change those signals of light into electric pulses to send to the optic nerve, which will then go to the brain. But it's a little bit different from just a general film because the retina itself has the center part of the film, which is called the macula. And this is the most specific area that allows the picture to come out perfectly clear. And this is also the center part of your vision is all in this macula. So in the photo on the right, it is a diagram of if you were to look at the retina face on. So what your eye doctor sees when they look into the back of your eye. And right there is the optic nerve on the left of the photo. And on the right of the photo is this dark area, which is called the macula. And the fovea is just the very, very center of it, but you can just ignore that aspect of it. So what is age-related macular degeneration then? So just like the word says, it is macular degeneration. So deterioration or breakage of the macula, which is again, that center part of the retina that allows us to see all these details. So damage to the macula affects our detailed vision and reduces the clarity of the objects that we're seeing directly, so heads on. So some patients will see that, the vision that they use to read or drive or even see television or do detailed work like sewing or threading or other crafts may be hindered by macular degeneration because all of that vision is what we use from our macula itself. It can also similarly reduce our contrast sensitivity. So the ability to see the objects in the same tone as their background might be affected as well. And because of that, specifically, identifying faces or seeing the curb on the sidewalk might be difficult as well. So what causes age-related macular degeneration? So just like the talk of today, age is a major part of it. So a normal part of aging does include changes to the macula, but there are certain modifiable risk factors that are associated with age-related macular degeneration. So modifiable risk factors mean that these are things that we could do to help prevent macular degeneration or help prevent the progression of macular degeneration. One of these specifically is diet. So it was shown that all related to kind of the oxidative stress that we talked about before, diet of leafy greens and kind of these like dark green, collard greens, those kind of vegetables can help prevent or help decrease the progression of age-related macular degeneration. And the number one cause of the number one modifiable risk factor for age-related macular degeneration is again smoking. So just by smoking or stopping smoking, you could help decrease your risk of getting age-related macular degeneration, and you can also help prevent the progression or worsening of age-related macular degeneration. Other things that are not really modifiable, meaning just our family history, genetics itself. If someone in your family had or has macular degeneration, that may increase your risk of getting macular degeneration as well. And another part is also our ethnicity. So the CDC actually says that over 14% of white or Caucasian Americans over the age of 80 are affected by macular degeneration. So like we talked about, the macula is the center part of the retina that allows us to see details and allows us to see things crystal clear. So when this is damaged, it can affect the details that we're seeing in the center part of our vision. So the photo on the right here, specifically the photo on the left, shows what our normal vision would look like if we're looking at a photo of two boys holding soccer balls. The same picture is that on the right of someone with of what it might look like of someone with age-related macular degeneration, because there is this large central spot that obscures the faces of the boys in the middle. And the remainder of the photo is even a little bit blurred as well. So we can't see them smiling, we can't see their hair, we can't really see their faces at all, but we just see the two soccer balls itself. And just like what we were kind of talking about today, the best way to protect your sight from age-related macular degeneration is to, again, have those regularly scheduled annual eye exams. The symptoms of age-related macular degeneration may be slow at the start. So by finding it immediately, by going to your ophthalmologist and then helping to prevent any worsening of it is extremely important as well. So during this examination, your ophthalmologist may be able to take a look at the back of your eye through your retina and specifically look at the macula to see if there are any of these changes. Your ophthalmologist might also give you what is seen here on the right. It's a photo of an Amsler grid. So the photo on the left is what a regular Amsler grid looks like. It's a grid with a dot in the center. And what your ophthalmologist might have you do is they'll have you wear your glasses like you normally would. Then you hold up the grid about a foot away from you and you cover one eye and you just look straight at that dot in the center. And then using your peripheral vision, you take a look at the lines that are going up and down, and you try to note any areas where you see a little bit of a curvature or any distortion of those lines. Then you do the same thing where you look at the dot, and then you look at the lines that are horizontal with your peripheral vision, and you try to notice any parts that are distorted. And by noticing any changes, you may be able to catch your progression earlier, and you can go to your ophthalmologist and say, you know, this area is a part of the Amsler grid where I never had a problem with, but now I do. And they might take a look at the back of your eye, might take some photos and assess that area to see if your macular degeneration is getting worse. So how do you get screened for macular degeneration? Just like we talked about, go to your ophthalmologist. But treatment for age-related macular degeneration definitely depends on the type of macular degeneration that you have. So kind of like we talked about before, there are certain studies that show that a particular type of age-related macular degeneration may benefit from certain supplements or vitamins. So if you have a type of macular degeneration that is able to be prevented or prevent the worsening of it with these supplements, your ophthalmologist might give you this medication. It's called AREDS 2. It's a supplement with a mixture of vitamins that slows down the progression of this one particular type of macular degeneration. Your ophthalmologist may also say to improve your diet with a lot of those leafy greens and omega-3 oils to help prevent the further worsening of this. But the main modifiable risk factor, like we talked about, is smoking. So stopping smoking will help prevent the progression of age-related macular degeneration. And then depending on the type of age-related macular degeneration, your ophthalmologist may suggest that you get injections of medications actually similar to the ones that we described previously for diabetic retinopathy, because a particular type of age-related macular degeneration can cause leaky blood vessels that will further worsen your macular degeneration. So by giving these injections in a properly manner can also help prevent the progression of that type of age-related macular degeneration. Any questions?
I've not seen any come in right now, but we do have someone's asking for a presentation on retinitis pigmentosa in the future. So
yes,
we might look at doing some more webinars in the future with you, Dr. Paulose.
no problem.
But I want to go ahead and pause the recording here. We have about 1 minute left and just want to make sure we get in our closing code here. So let me pause this. So thank you again so much, Dr. Paulose, for coming today and sharing all of your expertise and knowledge with us. And we greatly appreciate your time. And this hour, I don't know about you, but it flew by. So thank you so much for presenting with us today.
Thank you so much for having me, and thank you all for joining.
Absolutely. All right. Have a great rest of the day.